The usual question facing the orthodontist while doing a treatment plan for the patient: do I need to extract tooth or I can regain the space without extractions? In adult patients, there is no clinically significant growth, so alternative solution must be found to create a space. Space regaining can be achieved by stripping, derotation, expansion, and molar distalization. Traditional molar distalization techniques require patient compliance and cooperation with the headgear or elastics. Recently, several different intraoral procedures have been introduced to minimize such patient cooperation. The non-compliance therapy reduces such cooperation and increases the predictability of the results. In 2004, Dr. Luis Carriere, a Spanish orthodontist, introduced a new simple intraoral fixed appliance for non-extraction treatment of Class 2 and Class 3 malocclusion. He designed it with the most advanced three-dimensional computer technologies by using 3D software, the Softlander project. He called it Carriere Motion Appliance. This project was performed to review the literature and describe a method of maxillary and mandibular molar distalization by using a new intraoral fixed appliance, which is called Carriere Motion Appliance. The Carriere Motion Appliance for Class 2 cases is composed of the anterior pad, which is directly pointed to the canine or the first premolar in cases of a blocked out canine. The anterior pad hook offers an attachment point for Class 2 elastics. A nickel-free stainless steel half-round arm connects the anterior and posterior pad together. It has a slight curvature over the two maxillary bicuspid. The ball and socket joint were designed to resemble a human hip joint, allows for free yet controlled movement for derotating and distalizing the first molar simultaneously. It has a built-in stops that prevent unwanted molar over-rotation. The posterior pad, which is directly bonded to the maxillary first molar. The Carriere Motion Class 3 appliance is composed of anterior pad that bonds directly to the lower canine or the first premolar if the canine is impacted or plugged out, a hook in the anterior pad for the attachment of Class 3 elastics, the arm which extends distally over the two lower premolars, with a slight curvature to follow the contour of the dental arch. Between the second premolar and first molar area, it diminishes in size and forms an offset with a bayonet bend to produce a 10-degree distal of the molar. The posterior segment is flat to avoid interference with the teeth or brackets. Posterior pad with a special dovetail grooves for excellent bone strength and retention. The Class 2 Carriere Motion Appliance produces its effect by molar derotation around its palatal root, as studies show that 83% of cases with Class 2 Div1 associated with medial rotation of the first molar. So molar distal rotation will create a space that was occupied by his rhomboidal outline. It also independently moves each posterior segment on the right and left side from the canine to molar as a unit. The Carriere distalizer also acts by brightening a medially tilted molar by the distal force produced by Class 2 elastics on the anterior pad. While the appliance derotating the molar, it simultaneously produces a uniform force for molar distalization. In addition to the molar distalization, a canine distal movement produced by Class 2 elastic traction occurred to produce a Class 1 canine relation. The Class 3 Carriere Motion Appliance produces a molar distal rotation by means of Class 3 elastics attached to the hook in the anterior pad, which in turn transmitted to the posterior pad. In addition to that, the lower canines are distalized to achieve a Class 1 canine relationship. The sources of anchorage for Carriere Motion Class 2 appliance are the passive lingual arch, which is a lower lingual arch wire with a band containing hooks on the lower first molar, or preferably the second molar, to increase the amount of anchorage. The hooks provide an attachment for Class 2 elastics. The lingual arch wire may be associated with some degree of the proclination of lower incisors, so it may be unfavorable in some cases. It is preferred in cases where there is no crowding in the arch. Hamular lingual arch, which is a hamular first fit molar band on the lower six, with a round stainless steel lingual wire. The bands have medial and distal occlusal stubs. Two segments of wire are soldered occlusally to the stubs and are bonded to the occlusal surface of the premolars and molars. An E6 appliance, which is a vacuum-formed retainer, the material used should be 1 mm thickness because it is associated with a lower fracture rate. A window should be made on the buccal area of the lower first or second molar to allow bonding on the apical tube. A full mandibular fixed appliance is indicated in patients with deep curve of spine or mild crowding in the mandibular arch. Temporary anchorage device. This is the most effective way to accomplish the distal movement of the teeth compared to previous anchorage. It reduces the side effects of class 2 elastic, such as the lower molar extrusion and lower anterior proclination. Mini screws are inserted bilaterally in the maxillary buccal alveolus between the second premolar and the first molar, but this location is not preferred anymore because these mini screws may require periodic replacement to avoid interference with the roots of the teeth. The preferred site for the placement is the infrazygomatic crest, which lies higher and lateral to the first and second molar region. The sources of anchorage for Carriere motion in class 3 appliance are the upper E6 appliance with a direct bonded buccal tube on the first or second molar, a full bonded fixed appliance which is used for the leveling and the alignment of the upper teeth and to receive the class 3 elastics. Temporary anchorage devices such as the mini plates, mini implants, and mini screws. The mini plates should be placed on the external oblique ridge, lateral to the third molar area. To avoid interference with anterior-posterior movement, the mini implants and mini screws should be placed on the buccal shelf area rather than interradicularly. The Carriere motion appliance is supplied in multiple sizes, spaced in 2 mm increments. For the appropriate selection of the appliance, the distance from the buccal groove of the first molar to the mesial third of the canine is measured by using a pre-treatment model or by using a dentometer which is supplied with the appliance. In cases of impacted or plugged out canine, the shorty design which runs from the first premolar to the first molar can be used. The indications of Carriere motion in class 2 appliance. It is indicated as a phase 1 non-extraction therapy to correct the malocclusion. Then the case can be finished with any other appliance. It is also indicated in a unilateral class 2 patient with a blocked out or impacted canine. Class 2 Div 1 and the class 2 Div 2 cases also can be treated with Carriere motion appliance. It is also indicated in a class 2 cases with 3 mm open bite. While the indications of Carriere motion appliance class 3 are, it is indicated as a phase 1 therapy in the correction of severe skeletal class 3 malocclusion without extraction or surgery. Then the case can be finished with any other appliance. It is also indicated in dental class 3 and the class 3 with deep bite malocclusion cases. The Carriere motion appliance is contraindicated in patients with excessive lower facial height or with a vertical growth pattern, because molar distalization usually causes a downward rotation of the mandible. It is also contraindicated in patients with severe arch length discrepancy. Both the skeletal and dental open bite also contraindicate the molar distalization due to the wedging effect produced by molar extrusion. In patients with a convex profile, extraction treatment would be preferable to relieve such an aesthetic facial profile. The pterygoid vertical line on the cephalometric radiographic analysis is a vertical line passes through the posterior border of the pterygoid fissure. When the distance between this line and the distal surface of the upper first molar is less than normal, this may contraindicate distalization of the molars. Also, in patients with severe skeletal class 2 pattern is contraindicated for distalization. The molar is also contraindicated to be distalized when it is distally inclined. The advantages of Carriere motion appliance are the oral hygiene measures can be performed easily because it is bonded to the molar and canine only. It is a nickel-free appliance, which makes it a good option for the patient with nickel allergy, and sometimes it is made from ceramic. The distalizer is small, comfortable, and aesthetically acceptable to the patient. Its ease of bonding and activation without complex laboratory steps are also another advantages. Carriere motion appliance, when used as a phase 1 therapy, eliminate the competing force vectors inherent in traditional methodologies when traction is employed together with fixed appliance treatment. Also, it improves the masseter and temporalis muscle activity and reduces the overall treatment time. Studies show that patients with a class 2 malocclusion associated with a narrower airway dimensions. At the same time, patients with a class 3 malocclusion associated with a larger oropharyngeal airway dimensions when comparing them to a patient with a class 1 malocclusion. Atiyah and his colleagues concluded that the use of Carriere motion appliance class 2 resulted in an increase in the total oropharyngeal airway volume. Carriere motion appliance associated with some disadvantages such as toothache, wide opening difficulties, aching jaws, difficulty in eating and keeping the device clean. In addition to that, although it is considered a non-compliance therapy, Class 2 and Class 3 elastics still require patient compliance. The appliance causes an increase in the lower facial height of the patient. Also, the loss of anchorage is another disadvantage of the appliance unless an absolute anchorage is used. In low-angle cases, the patient is instructed to wear the elastics 24 hours a day except during meal, while in high-angle cases, the elastic wear should be limited to 14 hours including the sleeping hours. The patient may experience a mild discomfort for the first 3 to 5 days. The patient may be instructed to use a chewing gum or some orthodontist to prescribe a mild anti-inflammatory medication. Also, the patient should be instructed to avoid placing the tip of the tongue in the spaces created between the lateral and canine during distalization to prevent irritation to the area.